Recording in progress.
Welcome. The American Association of Neurological Surgeons is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The AANS designates this live activity for a maximum of 1 AMA PRA Category 1 credit. As a provider accredited by the Accreditation Council for Continuing Medical Education, the AANS must ensure balance, independence, objectivity, and scientific rigor in all its sponsored educational activities. In accordance with the ACCME standards for integrity and independence in accredited education, the AANS is required to disclose to the activity audience the relevant financial relationships of the planners, faculty, and any other individual in a position to control content of this activity. Those who have disclosed a relationship with ineligible companies are listed on the current slide. All disclosed financial relationships have been mitigated in accordance with ACCME standards. Planners, faculty, and any other individuals in control of content not listed have indicated that they have no relevant financial relationships or conflicts of interest to disclose for this activity. Credit claiming will be available in our learning management system, NeuroU. Claiming instructions are on the screen and will be shared again at the conclusion of this webinar. By the end of the week, participants will receive an email notification of enrollment to claim credit. This notification email will also include the instructions on the screen for your convenience. For any issues or questions regarding claiming credit, please contact education@aans.org. Now, to get us started, I would like to introduce Dr. Hajipanias.
Welcome, everybody. This is another exciting webinar in our latest highlights in neurosurgical oncology. Really excited that Raj Mukherjee from Johns Hopkins University is going to join us today to really talk about a timely topic. Just as a reminder to everybody, these are all recorded. They will be placed on the tumor section website for future viewing. And as mentioned by Tim, these are CME accredited. Want to thank the AANS, and I also want to thank our tumor section executive committee, Ashish Shah, Ankush Chandra, Yashua Ashkenazi, Kristen Huntoon, for really helping us make these possible. Dr. Ashish Shah is going to provide a formal introduction for Dr. Raj Mukherjee.
Thanks again, Kostas, and thank you everyone for joining us on these amazing tumor section symposiums. We have the honor today of having Dr. Raj Mukherjee from Johns Hopkins talk to us a little bit about his focus and his research plans. He focuses on the treatment of malignant metastatic brain tumors. He received his medical degree from Dartmouth Medical School and was recruited to Johns Hopkins, where he studied epidemiology and biostatistics and clinical design at the School of Public Health. He is a director of the Neuro-Oncology Surgical Outcomes Laboratory and neurosurgery, and they've been very, very prolific with their publications. He also did a skull-based fellowship at the University of Pittsburgh, and he's very interested in patient-centered pursuits. And we're very interested in hearing his thoughts today on the treatment and management of a very important question of how to manage elderly glioblastoma patients and the best treatment paradigm. So thanks again, Raj, for coming.
Sure. Thanks so much, Ashish and Kostas, Tim, Kristen, Yashua, and Ankush, and everyone for this forum and for the opportunity to speak here. I figured I would spend this little bit of time that we have going through some highlights of, to be data-driven about how we manage elderly patients with gliomas, and then end with some slides on some maybe new approaches for how we can try to prognosticate a priori for some of these patients, leaving some time for questions. So I'm going to just roll through the slides here. So we all know that GBM is a common and aggressive primary malignancy, especially impacting patients in their adult working years and elderly ages. And the typical paradigm has been a surgical debulking with maximal safe resection, and then adjuvant chemoradiation, and oftentimes upon progression, more experimental therapies. We generally think of that for folks who are, young and of working age. And historically, there's been some reticence to maybe be as aggressive surgically and with adjuvant therapies in elderly patients with gliomas, and especially glioblastoma. And I'm hoping to run through some historical data that we can hang our hat on, so that when we see some of these patients, we can, in a data-driven way, really give them the best care possible. I think a nice review on the topic was done by the Mason, Perry, and Malmstrom group back in 2015. And some of it includes some epidemiological work, but it also gives a nice overview of some of the really key and landmark papers over the last 10 to 15 years that included randomized trials of different surgical approaches, different types of radiation, as well as chemotherapy. And so that's what we're going to be highlighting next. Fortunately, the incidence of glioblastoma or high-grade gliomas in the very elderly population, and there are various approaches to how you could define that. Oftentimes at 70, 75, or in octogenarians is relatively low, about 9%, with survival rates of 1 year about 9%. So you can see as patients get older, their life expectancy is dim with GBM, but not perhaps as dim as we would have thought. I think, here's by decade of life, looking at the Greater Toronto area in a registry that they had, showing the relatively poor overall survival outcomes in patients who are octogenarians. And, I think because of that mindset, there had been for quite a bit of time, especially, going up to the early 2000s, an approach where oftentimes what was assumed to be frail or very elderly patients were often just given, were only offered a biopsy. And I think a really small but elegant a randomized trial was done back in 2003 in the European population, where they had an almost equal number of patients who underwent craniotomy for a malignant glioma versus a stereotactic biopsy. This was a single center series, but I think it's an important data point in our armamentarium, because especially after this data came out, to particularly demonstrate that patients who had a craniotomy as opposed to a biopsy had a notably improved overall survival. I think that helped to change the paradigm in the interim 20 years to actually start to be more aggressive surgically with these patients. Importantly, the time to clinical deterioration as measured in KPS did not exactly meet the threshold for significance, but again, it was a bit of an underpowered study, although important to justify more aggressive surgical approach. Moving a bit towards the treatment of radiation, the use of radiation in some of these elderly patients. Again, each of these paradigms that we think of as essentially standard of care now for adult age patients, surgery, radiation, and chemotherapy have over the last 20 years each been controversial in their own ways. I think this is a really elegant, again, a relatively small but elegant study published from the French group in the New England Journal of Medicine in 2007 that demonstrated both a progression-free survival improvement as well as an overall survival improvement in patients, in elderly patients, and this was defined as 70 or greater, in those receiving radiation therapy versus supportive care alone, which really started that conversation of once that diagnosis was obtained, to help ensure that they're achieving at least the basics of adjuvant therapy. Beyond that, I think particularly in the radiation oncology literature, there had been and has been continued concern about neurocognitive outcomes and deficits in some of these patients, especially when it comes to memory and overall quality of life. And, it is a lot to put patients through oftentimes, 5 days a week times 6 weeks for IMRT or radiation therapy. And so a nice paper was done by Rao et al. Back in 2004 that randomized patients to a standard 6 weeks of radiation of IMRT versus 3 weeks, with a similar amount of gray between each treatment arm. And I think one of the take-home points was that the patient's overall survival, as well as at least some initial markers of quality of life, which was the PROMIS instrument, were no different between these two patient groups, and it gave radiation oncologists as well as our broad multidisciplinary teams, an opportunity to allow a shorter course of radiation for these patients and really in a data-driven way. In addition to radiation, there had been thoughts and concerns over a decade ago about the utility of chemotherapy, I should say of 6-week radiotherapy versus hyperfractionated in a somewhat younger but still elderly cohort of patients. So this was a similar study to the JCO study, that was published in Lancet Neurology from the European group. The real take-home point from this was that there was no significant difference when it came to the hypofractionated versus the full fractionated group in terms of survival outcomes. Again, allowing our patients, especially if they are a little bit more frail, to still receive some adjuvant therapy, knowing that we're trying our best to help them with their overall survival. As alluded to sort of briefly before, this has been a pretty prolific group, Wolfgang Wick and others, sort of in this space of elderly glioma patients. Again, more than a decade ago, while there was this conversation of whether to give adjuvant therapy and how much adjuvant therapy to give to our elderly GBM patients, there was a subset or a study that really directly compared about 200 patients in each arm amongst patients that had a diagnosis of, at that point, malignant astrocytoma, to be randomized to temozolomide or radiotherapy. I think this is a broadly nice study that showed the equivalence when compared head-to-head of temozolomide versus radiation. And I think broadly speaking, given sometimes the difficulty of the logistic difficulty of having some of these elderly patients have radiation therapy, it showed at least providing temozolomide could be helpful for this group, particularly in those in that subset of patients that was MGMT positive or MGMT methylated. One of the concerns, particularly in the neuro-oncology community, that perhaps we don't think of as much in the neurosurgical community, but still important for us to think about as we see some of these patients in our postoperative clinic, are concerns about some of the side effects of temozolomide. While it's a pretty well-tolerated medication, especially aside from some issues with fatigue, there had been some reported concerns early on in its use with regard to seizures, and this was just a very simple but nice study from Journal of Neuro-Oncology demonstrating that even in elderly patients, a low incidence of seizures with temozolomide, really supporting the notion of both chemotherapy, of both temozolomide and radiation, as opposed to one or the other, which had been, at least in the 2000s and 2010s, a more prominent adjuvant therapy approach. There have been many different centers, including UT Houston and Miami, Hopkins, and others that have published their series of outcomes in patients in octogenarians with glioblastoma or high-grade glioma. This is Dr. Abdullah and Dr. Brem's series from UPenn, again, just demonstrating that additive benefit of full adjuvant and chemoradiation. Again, whether that radiation was full radiation or hypofractionated radiation, really the importance of beyond just getting a diagnosis, getting a good resection, as well as chemoradiation. One of the issues, particularly as we think about it as surgeons, is how aggressive we should be for GBM. And we've had, series within this webinar series talk about, different adjuvants that we can use intraoperatively, like 5-ALA, fluorescein, intraoperative ultrasound, and image guidance. But I think specifically when we see some of these elderly patients that are, at least for me, and I think for many others, there's this concern of, a frail elderly patient, how much are we going to push the envelope in terms of extent of resection? There are lots of papers that have demonstrated, greater extent of resection is associated with better outcomes, but there is this other side of the coin. And I think this is a paper that I had the pleasure of being associated with about 15 years ago at this point, that demonstrated, at least at an institutional series at Hopkins, that, if we cause a GBM patient a new motor deficit or a new language deficit, we're significantly impacting their median survival, reducing it by about 3 or 4 months. More recently, Miriam Rahman and her team at University of Florida had a similar paper in their series that similarly demonstrated that, if we cause a new or worsening deficit on a patient, we're really minimizing the impacts of our improved extent of resection. And I think a really important data point from Miriam's paper is that the rate of new or postoperative neurological deficits in their series was approaching about 30%. I think that was a really impactful time point or data point I will say personally, my phrasing oftentimes is that, oh, you may have a 1 or 2 or 5% chance of some kind of an issue. But I think including all deficits, including cognitive deficits, I think it's important to be cognizant of some of the limits that we might have with surgery. This has been looked at, how aggressive we should be with surgical resection and adjuvant therapy has been looked at with some national data sets as well, in addition to some of these institutional data sets that we've looked at. I had a chance to work with a current PGY1 resident at Oregon Health Sciences University named Julian Gendro, who used the National Cancer Database to look at the various impact of extent of resection, radiation, and chemotherapy, not at an institutional level, but really at a national level amongst several thousand patients. All of them were elderly, and we had a subset of octogenarian plus patients, and we found that amongst all comers, gross total resection, radiation, and chemotherapy separately and collectively really improved survival. They had more of an impact amongst just the elderly patients, but continue to have some benefit amongst all comers. And these are just some of the Kaplan-Meier curves demonstrating the utility of radiotherapy even in these elderly patients, as well as chemotherapy and gross total resection beyond just a biopsy or subtotal resection. Here's just the multivariate table for it, but there are a handful of other metrics that are important. We do need to be aware of patients' frailty, and that was something that was measured through this Charlson-Deyo score. With more frail patients being more prone, as expected, to have worse outcomes, but nevertheless, demonstrating the importance of gross total resection when possible, radiotherapy, and chemotherapy. A mirror study was also done by our group, Melanie Horowitz, who's a medical student at Hopkins, using the SEER database. And you can see here on the bottom, the same kind of findings that a gross total resection, adjuvant radiotherapy, and chemotherapy, regardless of age, even in this elderly patient population, is notable for significant improvement in overall survival. And again, here are just the curves demonstrating utility of gross total resection, chemotherapy, and radiation. Practically speaking, and this will get to that last little phase of the talk, thinking about some ways to prognosticate relatively easily from things that are already available in our electronic medical record. This was an overview of the topic of looking at frailty and different metrics of frailty and how to incorporate it into our workflow. I think while it's not always possible to truly modify frailty, there may be a subset of patients, especially within this elderly patient population, while they've been identified, but prior to their surgery, to undergo some sort of prehabilitation to try to improve their strength and to improve their functional baseline. Again, this is a bit of a pie in the sky kind of an approach at the moment, but it was our workflow and thought process to hopefully implement prospectively in patients in the future. We came up with a nutritional status score that could help prognosticate postoperative outcomes, including, frankly, survival in patients with glioblastoma. And so there are a lot of different metrics that we can use, normalized an index and albumin and other kinds of nutritional indices that are widely published in the non-neurosurgical literature. And it really is low-hanging fruit to try to prognosticate which of those patients that we maybe have a gestalt feeling may not do well after surgery or may be particularly frail, to be able to identify that, knowing that it does have some prognostic value in terms of their long-term survival. Another interesting study done by Saqib Huq, who's currently a UPMC, I believe, PGY5 resident, looking at different metrics of sarcopenia and their impact and their prognostic value in GBM patients. So, we know from the spine literature that patients that have sarcopenia are known to have worse outcomes and worse complications. And so really just by looking at our typical metrics of our typical preoperative MRIs, we were able to identify a threshold of 7 millimeters or less of the temporal muscle being a threshold beyond which patients were expected to have actually worse progression-free and overall survival. It seems to be a biomarker that correlates with age, albumin or nutrition, BMI, and KPS, and it's a metric that has demonstrated, particularly amongst patients with recurrent tumors, a significant association with overall survival. It's not a be-all and end-all, but it is a way that we hoping can help supplement the ways in which we can prognosticate. That was a bit of a whirlwind of a discussion, but hopefully it covered the main topics. I think as we think about our patients and their management, here are the references that were listed, and happy to take any questions. Thanks so much for your time.
Fantastic talk, Raj. I think it's a very difficult population to manage, and I think, the extent of resection and on elderly patients is a big question of, if you think you can get a gross total on someone who's 85 and they're playing golf, what does that mean? And I just want to get your thoughts on, on that, on someone who's, very functionally, we live in South Florida, so we have a lot of elderly patients, 85, 88 with like tumors that you could take out. And so, do you think it's worth going, for a gross total at that age? And then the other question I want to ask you, which I'll follow up on, is,
Yeah.
What do you think the role is now for these other invasive procedures like laser ablation in elderly populations,
Yeah. I will say, I didn't include it in our study, but I believe you guys at Miami had a paper on octogenarians with gliomas that underwent lit. And so, it's not something that we honestly are using a ton at Hopkins, but I think it might be a very elegant way to sort of toe that line between getting a diagnosis, addressing the tumor in a minimally invasive way, burning it instead of resecting it, and getting people, onto the next stage in terms of radiation and chemotherapy. So I think personally, I thought it was a really elegant paper. I think, for folks in their, octogenarians and thinking of them nowadays, honestly, I think is different than maybe even 20 years ago. There's a lot of octogenarians that are, active and driving. And I remember even in the early part of residency, anytime an 80-year-old was presented in M&M, it was an immediate almost red flag. I remember, and nowadays, it still is it's a yellow flag, I would say. And I think trying to toe the line, maybe through some of these predictor metrics, as well as I think probably even more so, maybe some elegant approaches like lit, to try to get them across the threshold, I think might be the next wave.
Hey, Raj, really nice talk. Enjoyed that. The point you made about how deficits and injury, in the elderly patient really, really are detriment to already a compromised outcome.
Mm-hmm.
And these are the things, the discussions we have at our morning conferences is kind of knowing when to stop, right? And that's in those types of patients, because we inherently want to take out as much as we can. But in those patients, and as Ashish mentioned, the 85-year-olds, the 88-year-olds, we're not doing them any favors if we try to go after it all, and then they can't play golf for their remainder of their life. So what's your thoughts on that, on kind of getting to that number that we talk about with extent of resection that is meaningful, and trying to get as much as you can, but willing to stop if you have to?
Yeah, I think it's a great point, and I will say, God bless Nader Sinai and his paper from back in, I think it was I want to say 2011 or so in Journal of Neurosurgery. I think prior to that, there were papers from Dr. Sawaya and his group that really talked about the importance of 95+% extent of resection, and a lot of papers on gross total resection. A lot of people talking nowadays about super total resection. But I think Nader's paper really elegantly, in a stepwise fashion, demonstrated that I believe the threshold was 78% or more. If you're able to get out 78% or more of the contrast enhancement, you're able to at least provide some benefit to these high-grade glioma patients. So I sort of use that as my internal gauge, especially for patients where I'm concerned about causing a deficit. I do remember in the early part of my residency, we would sometimes take people back. If they had a little nugget of contrast enhancement, we would take them back to surgery the next day. And I would say, after that paper came out, so maybe it was more like 2017 or something, was maybe Notter's paper. But I'd say after that point, I never had that happen again. We never went back to surgery again because we had some good data, rigorously conducted data to support, doing what's best and not causing a problem. So I actually internally use, in those tricky situations, I use that 78% to help me internally feel okay about, hey, maybe I didn't get all of it, but I didn't hurt. And hopefully that's helpful for others too. Yeah. So God bless Notter.
Yeah, I think and then the other thing that I think is also something worth discussing is, whether or not the elderly patients have certain mutations that make them different than like a patient in their 50s or 60s. And I wonder, as you get older, if you're, you just accumulate more mutations than someone else, right? So
yeah, and I think for folks that have been talking about super total resections and things like that, I think even without super total resection in the conversation, I think there are some new diagnostics like Belay Diagnostics, I believe, has a CSF test that is proposed to show whether someone's MGMT methylated or not. And I think if we had similar kinds of liquid biopsy kind of approaches to determine IDH mutation status, as well as more commonly MGMT methylation, that can help us maybe a priori figure out how aggressive we need to be or should be in a more nuanced way.
yeah, it's reasonable. Appreciate it.
Yeah.
Let's see if there's any questions from the panelists at all. If you want to put it in the chat, we're happy to take any of those as well. Or sorry, from the attendees. But I guess we're reaching that 5 o'clock time limit. But again, it was very awesome to hear your thoughts, and we're excited to see what your lab's going to bring forth on this exciting
Great.
field.
No, thanks so much, and looking forward to catching up with everyone at CNS this
Thanks, Raj, and everybody. The Tumor Section Symposium, register, please. It's coming up October 9th and 10th.
Absolutely.
We'll
We're going to see everybody there.
You guys see.
We'll talk more about it.
Take care.
Thanks, Raj.
Thanks everybody.
Thanks, Ashish.
Thank you. Bye.